while I'm doing that, let me also introduce today's fabulous speaker. So we're really honored to be joined by Driessen from Radboud University in the Netherlands. Ellen is a clinical psychologist and a fantastic researcher, particularly in personalizing mental health care, and most particularly for those with depression. She's got an incredibly impressive research background with some wonderful grants, doing some really, really interesting work on personalizing care, and is going to speak to us today about using data to personalize treatment for people with depression. So Ellen, over to you.
Thank you so much, Josh, and welcome everyone. Good afternoon, and thank you all for joining. So I think the Data Science for Health Equity is an amazing initiative. So it's a great pleasure as well as an honor for me to be here today and to present to you some of our research that is aimed at using data to personalize treatment for depression, or more specifically to personalize treatment selection for depression. So thanks so much to the Data Science for Health Equity initiative for this opportunity. So as George mentioned, I'm a researcher. I'm an assistant professor of clinical psychology at Radboud University in Nijmegen, the Netherlands. But I'm also a clinician. So I work as a licensed mental health care psychologist and a senior researcher at a large mental health care institute that is named ProPersona. And I work at the Depression Expertise Center. And here at this slide, you see a picture of our building in Nijmegen, where we house a clinic on the ground floor, where we provide daycare for 3 days a week at the first floor, and where we have a general outpatient clinic at the second floor, where I work myself. So the Depression Expertise Center is one of 3 depression treatment centers in the Netherlands that has a top mental health care quality mark. And I don't know if you guys have something similar in the UK, but in the Netherlands, this is a system where these quality marks can be obtained if you meet a number of as a clinic, you meet a number of criteria, and it indicates that we provide highly specialized patient care and combine this with treatment innovation and scientific research. So scientific research is really part of our clinic, and we specialize in the treatment of persistent depression, including also bipolar depression. So as a clinician, I work with many people with depression. And here you see a picture of one of these people. Let's say her name is Anna. Now, I very clearly remember having my second meeting with Anna. So in our institute, the second meeting, so the meeting right after the intake interview, the purpose is to discuss a patient's diagnosis and agree together which treatment to pursue. So that's what Anna and I did, right? We discussed her classification of major depressive disorder, and we talked about the various treatment options. We discussed how she might start antidepressant medication or psychological treatment like cognitive behavioral therapy or interpersonal psychotherapy, behavioral activation, or perhaps psychodynamic psychotherapy. And we talked about the differences between these treatments. And then when we came to the point where Anna had to decide which treatment she would pursue, she asked me, also based on my scientific knowledge, which treatment I would recommend for her. And then I had to answer that I couldn't really. That on average, there is not much difference between these treatments in terms of their efficacy. But that we also see huge variation in how individuals respond to these treatments. And that at this point, we do not know which treatment would work best for Anna specifically. And I still remember that meeting so clearly because I found that answer quite unsatisfactory. And experiences like these in clinical practice have inspired a line of research that is aimed at coming up with better answers for people like Anna. And what I would like to do today is to tell you about this line of research. I also realized that many of you are in your lunch breaks in the middle of a busy working day, and you have another busy afternoon ahead. So maybe, it might be a little bit difficult to take in a lot of new research findings. So that's why I'm going to make things really easy for you today by saying that there's only one thing that you might want to remember from this presentation. And that is that we need personalized treatment selection for depression. And when I say personalized treatment selection, I mean matching people with depression to the treatment that they are most likely to benefit from. And in the next 30 minutes or so, I will argue how I think that we can use data to help us reach this aim. And I will give you some examples of the work that we are doing to, hopefully get us there in the future. Okay, so how come that we don't really know that well what works for whom in depression? Well, I think one of the main reasons is the lack of statistical power in individual treatment studies or randomized clinical trials. So the sample sizes of these treatment studies, of these randomized clinical trials, so the number of participants included in these studies, are typically based on identifying an intervention effect. Right? We want to show whether a treatment is more effective than a control condition, or whether treatment A works better than treatment B. And the number of participants calculated to be included in such a study is based on showing such an intervention effect. However, if we want to examine which participants benefit from which treatments, much larger samples, much larger number of participants are needed. And that is where I think individual participant data, or IPD, meta-analyses can come in. And I can't see all of you, but I can see some of you. And I'm curious, who of you is familiar with this technique? Can you please raise your hand if you know what an individual participant data or an IPD meta-analysis is? Yeah, I see some hands, but I also don't see hands from everyone. So let me just thank you for responding. Let me just briefly explain. So please note that an individual participant data meta-analysis is markedly different from a conventional, a regular meta-analysis, with which many of you are probably familiar. Many of you have probably seen or heard about or have seen a conventional meta-analysis presented. So with a regular conventional meta-analysis, what you do is you conduct a systematic literature search, and you identify those studies in the scientific literature that meet the inclusion criteria that you specify. So you select those studies, and you then extract study level characteristics from the publications of these studies, so the published reports. So let's say you were interested in, for instance, the association between participants' age and treatment outcome. You would extract the mean age and the average treatment effect of each study sample from the publication, and you then examine the relationship between the two across the studies. Now, with an individual participant data, an IPD meta-analysis, you also conduct a systematic literature search, right? But instead of extracting study level information from the publications, you reach out to the authors and you ask them if they are willing to share their studies data set at the level of the individual patient. So instead of working with average age and average treatment effect of extracted from the publications, you can work with age and treatment outcome of each individual included in each of the data sets in your meta-analysis, and that strongly increases sample size and the statistical power. Well, IPD meta-analyses also have some other advantages over conventional meta-analysis. So for instance, you can use the same statistical techniques across all studies to estimate the treatment outcomes. Or you can apply newer, more powerful technique in the case of older studies. And sometimes you can also get access to data that has been collected but has not been reported in the publications. So, yeah, let me give you some examples of a research project that we started to examine which patients might benefit specifically from one depression treatment for depression using these IPD meta-analyses techniques. And the psychotherapy that we are focusing on here is a short-term psychodynamic psychotherapy. And I won't go into too much into the technical details of the methods at this point, though I'd be happy to answer any questions you might have about it at the end of the talk. But for those of you interested, I'd like to refer you to the detailed study protocol of this project that was published in BMJ Open, and that is available open access. But before we dive into this in more detail, I'm also curious, who of you is familiar with short-term psychodynamic psychotherapy? Can you also please raise your hands if you know what short-term psychodynamic psychotherapy is? Quite some hands. Yeah. And also, I'm also curious, who of you is a clinician practicing psychodynamic psychotherapy yourself? Oh, not so many hands there. Okay, thanks. Thank you. So many people, when we say psychodynamic psychotherapy, for many people this raises is associated with images like these, right? Here we see Sigmund Freud in his office in Vienna at the at the beginning of the previous century, and on his famous sofa lies a princess, Princess Marie Antoinette. Well, this is what short-term psychodynamic psychotherapy looks like today. So many differences, right? No sofas involved anymore, and luckily it's also not only accessible for the elite, but luckily to many people in various countries. Also many more female therapists today, and short-term psychodynamic psychotherapy, as the name implies, is also notably shorter than the original psychoanalysis. And short-term psychodynamic psychotherapy, or STPP short, it refers to a family of interventions that relies on the original psychoanalytic theories of Freud and later thinkers. And in STPP, thoughts, feelings, desires, behavior are related to early experiences. And STPP is based on the notion that increasing insight in unconscious wishes, motives, intentions can alleviate psychological complaints. STPP, as I said, it's a family of interventions, and one example is the dynamic interpersonal therapy, which I think is part of the UK IAPT program, right? Yeah. So short-term psychodynamic psychotherapy, STPP, it's frequently applied in clinical practice. It is an empirically supported treatment for depression, and various meta-analyses have shown that it is more efficacious than control conditions. And a couple of large RCTs have also shown that it is not inferior to cognitive behavioral therapy, which is worldwide considered by many the gold standard treatment for depression. And so large RCTs have shown that psychodynamic psychotherapy is not inferior to CBT in the treatment of depression. At the same time, we also see this large variation in response to psychodynamic psychotherapy from patient to patient, and we don't really know, for which patients might benefit specifically from this treatment. And that was what we were trying to find out in this project. And I'd like to show you a couple of examples, starting with this first study, which is an IPD meta-analysis focusing on the efficacy of adding STPP to antidepressant medication. Again, I won't go into detail here too much regarding the methods at this point, but briefly, we conducted a large systematic literature search identifying randomized clinical trials that compared medication against combined treatment of medication plus short-term psychodynamic psychotherapy. We contacted the authors and we asked them to share their data with us. We checked these data, we combined them into one database and analyzed that with one-stage IPD meta-analysis using mixed effects models. And here at this slide, I'm showing you the title page of our paper because it lists our collaborators, so the investigators sharing their data without whom conducting projects like these is not possible. So a huge thanks to the researchers collaborating and joining in these efforts. So as you can see, this type of work really is a joint effort. And here we work with research groups from the Netherlands, from Italy, Switzerland, but also from Chile and from Mexico. So we are focusing right on the addition of antidepressant medication, the addition of psychodynamic psychotherapy to antidepressant medication. And we included 7 RCTs that compared antidepressants only to antidepressant medication plus psychodynamic psychotherapy. There were 7 trials that met our inclusion criteria, and we were able to obtain the individual participant data for all these studies, though the sample size was relatively modest. We included 482 participants. And we found that a combined treatment of antidepressants and STPP was significantly more efficacious than antidepressants only. But the effect size was rather small at treatment completion. So as some background information, usually a Cohen's d of 0.24 is considered a clinically significant effect. So it is a clinically significant effect, but on the small side. Interestingly, the effect size was somewhat larger at follow-up. Now, we all know that treatment resources for depression are scarce, and because adding STPP to antidepressants requires investments, financial investments, time and effort on the part of patients and clinicians, we thought it would be of considerable clinical importance to know for whom this addition is beneficial and for whom this might be less the case, especially given this small effect size at post-treatment. So in a second study, we tried to explore that question using the same data set of 7 RCTs and 482 participants. And we had requested all from the investigators who shared their data, we had requested to share with us all the baseline participant characteristics that were assessed in the trials. And we examined these baseline characteristics that were assessed in 2 or more studies as potential moderators of the efficacy of adding STPP to antidepressant medication in the treatment of depression. And we found here that adding psychodynamic psychotherapy to antidepressants was more efficacious for patients with high rather than low baseline depression levels, and for patients with a depressive episode duration of more than 2 years compared with patients with shorter episode durations. So we found that adding STPP to antidepressants might be particularly efficacious for individuals with relatively high baseline depression scores and for individuals with chronic episode durations. And for these patients, we found that we saw that the effect size of adding STPP to antidepressant medication is largest. And so these findings need some validation, but they suggest that depression severity and episode durations might be factors to consider when adding STPP to antidepressants and might contribute in the future to personalizing treatment selection for depression. The last study I want to share with you from this meta-analysis project is another meta-analysis, somewhat larger, including 11 studies and focusing on the comparison of psychodynamic psychotherapy versus control conditions. So in this case, we don't focus on the addition of STPP to antidepressant medication, but we focus on the comparison of psychodynamic psychotherapy versus control condition. And in this study, we found that STPP resulted in significantly lower depressive symptom levels than control conditions at post-treatment, which is consistent with previous conventional meta-analyses. The effects we found were somewhat lower, still clinically and statistically significant, but somewhat lower effect sizes than in the conventional meta-analyses. And we think that is because we were working with the original data and able to standardize these data analyses procedure, resulting in somewhat more precise, but maybe a little bit more conservative effect sizes. We again found here in this study that STPP was more efficacious for participants with longer rather than shorter depressive episode durations. And in this figure, you see this finding represented. So while participants with shorter episode durations in the left side of the panel, panel A, showed similar decreases in depression severity in the two conditions, so the control and the STPP conditions. Participants with longer episode duration showed larger decreases in depression severity in the STPP condition compared to the control condition. And so these findings are in line with the previous study, right, that found that adding STPP to antidepressants was also more efficacious for participants with longer episode durations. And episode duration has also been observed to moderate the effect of antidepressants combined with STPP versus antidepressants combined with cognitive behavioral therapy in one RCT, one previous RCT. Such that combined treatment with STPP was more efficacious for participants with episode durations, with longer episode durations, and CBT combined with antidepressants was more efficacious for participants with shorter episode durations. And it has been speculated in this regard that individuals with longer episode durations might have depressive symptoms that are more influenced by their personality structure, resulting in more complex working alliances and transference feelings. And psychodynamic therapists are trained to elaborate on these therapeutic relational aspects if necessary. So that might, it's speculation still, but that might be a potential explanation for these findings. And for those of you who are clinicians, I wonder, who of you are clinicians treating people with depression? Can you please raise your hand if you do? Yeah, so thank you again. Some of you might think, okay, can I now best offer my next patient coming in with a chronic depression, can I best offer this patient short-term psychodynamic psychotherapy? Well, I think it's a little early to conclude that. These findings are observational and they need to be replicated in prospective studies. And also important, we can't really speak at this point to the comparison to other treatments. In other words, we don't know whether these findings are specific to psychodynamic psychotherapy for depression, or whether they might also be found if we were to investigate that in other treatments, for instance, CBT. But at this point, there are no individual participant data meta-analyses that have examined that question. But that does bring me to a project that we are currently working on that is aimed at further improving treatment selection for depression using data by comparing 5 widely used and empirically supported depression treatments. And this is the VENI project. We call it VENI after the grant program from the Dutch Research Council, or NWO, that funded this project. It is still ongoing, so I can't present you all findings yet, but I do want to show it to you as another example of how we can use data to personalize treatment selection for depression. And this research project has 3 aims. The first aim is to develop an approach, a data analysis strategy really, to match people with depression to their optimal intervention using combined data from multiple clinical trials. So luckily we don't have to start from the scratch here, as there is an existing method to match people to their optimal depression treatment. This is named the Personalised Advantage Index, and it is developed by Rob de Rubis and Zachary Cohen from the US. The Personalised Advantage Index, but currently this method can only include data from 1 randomized clinical trial, so 1 depression treatment study. And that then has limitations regarding to sample size and also generalizability beyond the study that the sample participants that is studied. So the first aim of this research project is to extend the Personalised Advantage Index so that it can incorporate data from multiple trials to improve statistical power and generalizability. Well, okay, how do we do that then? Well, here on the left side of this slide, you see our team, the people working with us to do that, and on the right hand side, you see the team of experts working with us, and these are experts in depression treatments, network meta-analyses, IPD meta-analyses, IPD network meta-analyses, predictive modeling, machine learning. And what we did, we identified the methodological challenges when extending the Personalised Advantage Index for using combined data of multiple trials. And we interviewed these experts about potential solutions. Then we hosted a consensus meeting in Nijmegen last year, bringing all these experts together in one room and discussing about these potential solutions. And this resulted in a detailed study protocol. It is currently, we submitted it for publication, and we're currently working on the revision of it, but the preprint for those researchers of you interested, it can be accessed on Psych Archive. So that's how we developed the data analysis strategy for the project. The second aim of the VENI project is to build a database including individual participant data from randomized clinical trials worldwide, covering 5 widely used depression treatments. So instead of focusing on one, the psychodynamic psychotherapy discussed previously, we now focus on comparing multiple active depression treatments. And the eligibility criteria for trials to be included in this database is that they are randomized clinical trials focusing on adults with depression, and depression is defined as either meeting a diagnosis for a unipolar depressive disorder as assessed by clinical interview, or presenting, reporting an elevated score on a symptom measure of depression indicating clinically significant symptoms. And these RCTs need to compare at least 2 of the 5 interventions that we are interested in. And those are antidepressant medication, cognitive therapy, interpersonal psychotherapy, behavioral activation, and again, short-term psychodynamic psychotherapy. So in terms of collecting the IPD, the individual participants' data, we have a multi-step contact protocol to get in touch with the authors. We really trace them like detectives sometimes, and then stalk them until we get a response. And we ask them if they are willing to share the data of their trials. In return, we offer co-authorship on the publications that are based on their studies data, and a use of the aggregated database, provided that the original researchers approve the use of their data for this additional purpose. We request anonymized participant level data items, including all outcome variables that are assessed prior to, during, and after treatment, also in the follow-up period. Item level data for the depression outcome measures, so the data at the level of the symptoms as well. And again, all potential moderator variables, so all baseline characteristics that are assessed in the trials that might potentially be related to differential treatment effects. We then check the integrity of the data sets we've received. So we check whether they include all participants randomized to treatment in the trials. We check whether the data matches what is reported in the publications. We check for invalid, out of range, inconsistent data items. And we go back to the authors if we find some discrepancies. We extract study level characteristics to describe the studies in our database, and we assess the risk of bias in these primary studies. We then use a spreadsheet and code-based system to read in these data sets into the aggregated database. And so far, we have identified 96 studies, 96 RCTs that meet our inclusion criteria, quite a large number. Our detective and tracing multi-step contact protocol seems to work, because we have been able to contact 92 of these research groups of these studies. We are still trying to trace 4 authors. Those are studies conducted many years ago, people who have left academia. So it's quite difficult to trace them, but we haven't given up yet. For 28 studies, including 1,700 participants, IPD could not be shared. Most often because the data at the level of the individual participants simply was not retained, so it was thrown away, unfortunately. We had a few studies where data could not be shared because the original participants didn't provide the required consent to share it with a third party. For 5 studies, data sharing is still in progress, and for 59 studies, totaling more than 7,000 participants, we have obtained the IPD, and we are currently merging all that and trying to standardize it so that it is all in one database. And then what we eventually aim to do, hopefully in the next year or 2, is to apply the data analysis strategy that we developed to this database to create a depression treatment selection tool. And we envision this tool as a simple web application in which patient values can be entered, and that then generates outcome predictions for each of the 5 treatments studied. And we hope that in the future, such a tool can be used, and we see that it can be used as part of the shared decision-making process. So to eventually in the future be able to provide better answers to people like Anna, and match the many people with depression to the treatment that they are most likely to respond to. So to use data to provide these people, their clinicians and society, a means to make more efficient use of the existing treatment resources for depression. With that, I would like to conclude. I'd also briefly like to say that the individual participant data that we collect for both the projects discussed, so both for the psychodynamic psychotherapy IPD meta-analysis project and for the VINI project, are available for future research, provided again that the authors of the original studies approve the use of their data for this purpose. So for those of you researchers who might be interested in this, please feel free to contact me. You can see my email address here if that is of interest. So with that, I'd like to thank you for your attention, and I hope to have provided some examples of how we can use data to personalize treatment selection for depression. Thank you.